The number is still increasing. Should we give it 30 more seconds?
Yes.
Yes, absolutely.
Okay. I would like to welcome everyone to this ENS webinar from the ENS Neurotrauma section. And I'm very honored to host this webinar with two prominent professors, Professor Peter Hutchinson from Cambridge in UK and Professor Anthony Fugagi from Cape Town in South Africa. And the webinar will be about 1 hour, and we will each present our presentation, and then we will have 15 to 20 minutes for discussion. And please feel free to post your questions and comments in the Q&A section and not in the chat window. And we will try to make our best to answer as many questions and discuss as many comments as possible at the end of the webinar. So as I think most of you are familiar with this live map from Johns Hopkins, which covers the total global cases regarding COVID-19 and the global deaths, which have increased more than 1 million right now. And maybe most of us or several of us have went through this fire, and but the reality is still true for many of our colleagues around the world. This map is for the active cases right now, which shows that there are areas in the world that are still highly affected by this. And regarding the neurological manifestations and symptoms of COVID-19, which I will refer to soon, the coming slide, I will just tell you about the SARS-CoV-2 virus that most of you are familiar. That is for the coronavirus family, and there have previously been two epidemics and outbreaks with the SARS-CoV-1 and MERS-CoV, which was had a much higher mortality rate than the SARS-CoV-2, but they were geographically much more limited than the pandemic that we have right now. And the neurological symptoms were reported from the Wuhan region quite early from this report, where they reported studied 214 cases, where they showed that more than about half of the patient demonstrated neurological symptoms in form of cerebrovascular events, impaired consciousness, and also a small group with muscle injuries. Several other studies came following this one with neurological symptoms, and this one is a survey from the UK where hospitals could report on neurological symptoms that were admitted to their units. And most of the cases were cerebrovascular events, but also altered mental status, and a few patients with peripheral nerve injuries were reported. And by July, there had been several reports which were summarized in this review paper with different types of neurological symptoms, encephalitis, ADEM, the GBS, cerebrovascular diseases, and it seemed that these events had different time points where they presented following the symptom onset. For us in the Uppsala County, this was manifested in a severe case of encephalitis in early April with a female, 50-year-old female, which was previously healthy, and showed 3-day symptom with mild symptom of COVID with coughing and fever, and became unconscious after 3 days. And the usual workup did not show anything in the CSF, and the first CT was negative, but the patient's GCS was deteriorating, and the MRI showed acute necrotizing encephalopathy. And we could, following repetitive lumbar puncture in this patient, we could detect the virus in the CSF after 4 weeks. And at this time point, we didn't know as much as we do now, of course, so this was a scary case, and we did not know much about the neurological manifestation and the causes of it. And what we did also in this patient was to measure the neuronal injury biomarkers, and we could see that tau and FL were extremely high in this patient, and it corresponded with the Creutzfeldt-Jakob disease, actually. What we did with this patient was that she received plasmapheresis and recovered following that treatment, but we cannot be sure that it was not the natural cause of the disease and it was the treatment per se, but it was interesting. And what happened following this case was that we initiated a large study in Uppsala with the COVID-19 Neuro, which is a multidisciplinary project, and it's also preclinical basic science and the clinical research in order to try to understand the different aspects of neurological manifestations and the effect of COVID-19 on the neurological, the CNS.
Ma'am, would you like to show your screen?
Oh, you don't see my screen?
No.
Ellen, we can't see your slides. I'm sorry.
Oh, I am so sorry. You should have told me earlier.
Well, I thought it was just me being stupid.
Oh, I am so sorry about this. So let's do this. I just show you briefly my slide. Okay. So everybody, I'm very sorry. So this was my first slide where I introduced this webinar from the Neurotrauma section, and then I showed these 2 maps from the Johns Hopkins University, which you all are familiar with the cases. And then I had these 3 papers reporting on the neurological symptoms associated with COVID-19. And then this was the case report that we published in Neurology with acute necrotizing encephalopathy, which initiated the whole COVID-19 Neuro project in Uppsala in order to assess the neurological symptoms and the diseases that are affecting CNS associated with COVID-19, which is, as I mentioned, is multidisciplinary and basic science and clinical work that we, translational research projects. And I will just briefly, I mean, we have initiated more than 20 studies with this. I will just briefly tell you about the studies that are in review and published. And for example, we studied the critical illness polyneuropathy and myopathy in 120 ICU patients and measured the markers of neuronal injury, tau, NFL, and GFAP, and could see that in particular the NFL level were increased in patient developing SIN and SIM at an early stage before the onset of the symptom, and that this could be used as a biomarker in patients in the ICU suffering from the COVID-19. In another case report where we had a 40-year-old male healthy, also suffering from severe encephalitis, where we could not find anything in the usual workup in the CSF and other tests that we perform usually. We performed the test with mice slice using the CSF on the mice brain tissue, and where we could see that there was a severe autoimmune response from the CSF of this patient, which could show that there is a strong autoimmune component in this disease for some of the patients. Let's see now this one. And maybe many of you who have tried to study this patient or work with this patient know that the usual workup of the CSF in these patients with neurological symptoms turn out to be negative. They don't have so many cells or any other pathology that you can find. So what we try to do is try to identify other markers in the CSF that can indicate neuronal injury or the severity of the injury, and if the CNS is affected by this virus. And what we could see that NFL is a promising biomarker, that it can distinguish these patients with neurological symptoms at an early stage and distinguish between mild and severe COVID cases. And in another study, we used two different methods developed at the Karolinska Institute and Uppsala in order to see if we could detect antibody against two different spikes of the protein in the CSF. And both methods turned out actually positive and indicated that intrathecal antibody production in this patient. So these are coming studies, and we will learn much more from our center and many other centers that are performing this research in order to treat these patients with neurological symptoms when we meet them at our departments. And one of the reasons that this was possible for me as a neurosurgeon to perform was that, of course, I was helping other colleagues at other departments, and also that we did a reorganization of the neurosurgical department and did not perform what we usually did at our department. I can just skip this slide. This is about the post-mortem analysis that we do on the brain tissue. So during this time in the March, when it was the wave actually hit the Stockholm area and also the Uppsala County, we tried to follow the recommendations that were out there for our neurosurgery department. And one of the first one was from the American College of Surgery, and I'm sure many of you have your local and national recommendations that maybe look similar and maybe was out earlier than this. And basically what they recommend was to reschedule the elective surgery, try to limit the visitors to the COVID-19 patient. We actually implemented a total prohibition of visitors at the whole hospital for all wards. And what they also recommended was to have separate or dedicated ER and ICU departments for these patients, which we also had, and also dedicated staff to take care of the COVID-19 patient. And I think most of us who was hit by this wave experienced that this was not possible, that our colleagues from other departments needed to pitch in to help to take care of these patients. Another recommendation that was very helpful and was published from the ENS was how to triage urgent neurosurgical procedure during this COVID-19 outbreak. And they generated this adopted elective surgery acuity scale, which basically divided our surgical procedure into 3 tiers, where the first one was surgical procedure that could be postponed, and the third one was what they recommended to not to be postponed, of course, if possible. And it was the malignant brain or spinal tumors, brachial plexus injuries, chronic subdural hematoma, progressive cervical myelopathy, and congenital defect surgeries. Also, another nice early European publication was from the German Society of Neurosurgery, where they divided different sections of neurosurgery and prioritized surgeries that should be performed if possible. And it was, of course, the malignant primary brain tumors, subarachnoid hemorrhages, myelomeningocele, and hydrocephalus, and traumatic brain injury, and also some of the acute peripheral nerve injuries. A nice paper that was published from Mathisen et al., which are the group of ENS Ethical Legal Committee, was in order to assess the situation in Europe and also in Israel is included in these countries, and how the neurosurgical departments manage this COVID-19, is this paper published in Acta Neurochirurgica. And what they did was to send out questionnaires to centers in Europe and in Israel, and 25 of these centers in 18 countries responded. And they had to respond, for example, the first question was how their centers and department made prioritization, and if they had a system implemented early on or first in March. And more than 1/3 of the centers responded that the system was implemented first in March, and one can discuss, was it too late or early enough? Another question they had to respond to was that they needed to grade their situation at the end of March during the pandemic. And it was 3 categories: stable but with concerns, difficult with extreme measures, or desperate. And the good thing was that at least 14 of these centers had stable situation but with concerns, but 10 centers had difficult with extreme measure, and 2 were unfortunately in desperate situation. Another part of this survey was that the responders had 7 hypothetical cases that they need to make judgment, or they need to evaluate if they were operated in December, and if in March they will still operate these patients. And as you can see, the cases are glioblastoma, meningioma, cervical spinal stenosis, 3 different cases of ICH with different age, in different age group, and then a subarachnoid hemorrhage cases. And as you can see, the case that was mostly affected was the cervical spinal stenosis, that people chose not to operate in March compared to December. But also the tumors were affected, and also the ICH case with an older patient were severely affected by the pandemics. The last section was also an elegant put question, where the responder had to estimate the time to surgery in December compared to March for the elective patients. And it was the glioblastoma, meningioma, and spinal stenosis. And what one could see from the responses was that regarding the glioblastoma cases, 44% had altered expected time to surgery, which means it was either delayed or it was not went to surgery. For the meningiomas was much higher, it was 76%, and for the spinal stenosis was 70%. And we still, and I think this case is for a large number of neurosurgical units, although 25 centers was included in the study, and we still don't know the impact of these prioritization and alteration that we have done at our departments. When it comes to the Uppsala University Hospital, this is numbers for the whole hospital for elective surgeries in 2019 compared to the same time period in 2020. And what you see is different weeks of the year. And this is where COVID hits our area. And as you can see, there's a 17% decrease in the elective surgeries compared to the previous year at the same time period. And but the good news was that acute surgery was only 2% decrease, which means that we were still able to provide the acute care for most of the patients that were admitted to our hospital. And for the neurosurgery department, the trend was the same. Our elective surgery was decreased by 18%, while the acute surgery was decreased by 4%. And of course, this is something we really need to have to look at and try to understand what type of surgeries it was and what kind of consequences it have. And this is just a preliminary result, but we try to look at this data, and what we see that for example, the ICP monitoring and the vascular aneurysm treatment was the procedure that increased during this time period. And one considers, did we monitor more than we evacuate or extirpated tumors or bleedings? And did we choose endovascular treatments over surgical procedures? What decreased was the VP shunt. This is mostly the normal pressure hydrocephalus and chronic subdural hematoma. And that can have different explanation, because my impression is that the people with chronic subdural hematoma that sick were admitted, got treated, but there might be less trauma or less tendency of the older people to seek medical health if they have symptoms that they would seek for if it was not the pandemic. And when it comes to the neurotrauma in Uppsala, we try to compare it to the Stockholm numbers. And for the Uppsala, when we compared to the previous year, it was quite stable, did not change the number of neurotrauma that was admitted, while for the Karolinska Hospital, the number decreased 25%. And we still don't know really what that, why this was the case. Was just the accident numbers or traumas less, or were they referred to different hospital? One of the explanations is, of course, that the hit of the COVID-19 was totally different between Uppsala and Stockholm. And what this map shows is, this is the trend and the curve for the cases in the Uppsala region, and this one is from Stockholm. And as you can see, there's a tenfold difference between these two areas. And if we just take a snapshot of mid-March, what we see that we had only 12 intensive care cases, while in Stockholm they had more than 144, and the increase in their cases were much more steeper than what we had in Uppsala. And that also maybe gave us more time to prepare and perform studies, and also have the same number of amount of cases of, for example, neurotrauma. This was about our experience, and I am happy to hand this over to Professor Hutchinson for continuous. Let's see, I think there.
Great, thanks very much, Ellen. So I'm going to talk about some of the aspects of the COVID-19 pandemic and how it's impacted on neurotrauma and neurosurgical management. So I'm going to talk about some of the epidemiology, neurosurgical practice, guidance and testing, and then some of the surgical research that's specific to COVID, to follow on from Ellen's talk. So I'm going to focus on the UK epidemiology because I think it's fairly representative of some of the other countries in Europe, albeit with some different delays. So, of course, we are all wearing masks, and of course, also we don't know how long that is going to go on for, but I expect for many, many more months. If you look at the data across the world, clearly there's been a dramatic difference in the numbers of cases, but very much based on population size. And the UK data down here is we've had quite a large number of deaths, disproportionately over 42,000 now, patients dying with COVID. That's 619 per million of the population. And whilst that has settled over the past 2 to 3 months, sadly what we're now beginning to see is a further rise in terms of the second wave. The ICNARC is an organisation of research and audit based in London, looking at the intensive care data, and has mapped very carefully where the COVID-19 cases have occurred in the United Kingdom, and most of them are based, as one would imagine, around the larger conurbations. So in the first wave, it was the Midlands, the Northwest, and London were particularly hit hard. It was the Easter weekend when we had the peak of cases, and then with the government lockdowns, which were quite severe and hit the country very hard economically, we saw quite a dramatic decrease in the numbers of patients, but sadly, this is now, as I said, beginning to rise again. If you look at the data from ICNARC on the intensive care unit, the overall data shows that if you are admitted to intensive care, then your prognosis is generally very poor, and we can see here that the mortality is approaching 40% of those patients in ITU. What about practice and guidance? So it was recognised that the National Health Service may well be overwhelmed at the time of the first wave, and on the background of that, the government opened a number of what were called Nightingale hospitals. This is the example from London. Interestingly, this had the provision for thousands of patients, but in the first wave wasn't really used, but does remain available for use in the second wave. The Society of British Neurological Surgeons set out a number of guidance documents, and these are similar to the ACS document that Ellen shared and the document from the German Society. And I think what we all recognised is that whilst COVID patients were clearly a high priority, it was important that we maintain surgical practice for non-COVID patients. And there were many, many concerns about that, particularly in neurosurgery, ENT, in procedures using drills or endoscopes. So very early in the pandemic, we set out our strategy, particularly in terms of the high-risk surgery, in terms of the upper respiratory tract. And this was to define a safe approach for endoscopic microscope surgery to the pituitary gland and skull-base lesions. And this was led by my colleague, Angelos Kolias. And what we've done is defined operating practice procedure for this high-risk surgery with a risk mitigation approach. During the peak of the pandemic, we were operating in full PPE for all patients. That was pretty unpleasant. It was quite arduous, and it all became very difficult. But with improvements, reduction in numbers, and better testing regimes, currently we are free from unusual PPE measures. We're using our standard measures for the majority of patients. In terms of the neurotrauma section and neurotrauma practice, there was a concern in terms of access to both critical care and surgery. So we put out this guidance categorizing those patients who merely needed to attend the ED, so continued to be managed by NICE head injury guidelines, the obligatory inpatients, again recognizing the need for admission, but looking carefully at whether we may need to triage or ration the patients going to major trauma centers and neurosurgical centers. So a recognition that all patients needed neurosurgery operations would need to come, but a provision to manage patients with diffuse injury non-operatively in non-neurosurgical centers. And that is this, what we call the maximal remote support. And then a strategy, of course, for the devastating brain injuries for palliation. So we recognized early that those who will benefit from admission to major trauma centers are those with easily reversible conditions. So these are those with mass effect who need urgent surgery. So these are given the highest priority. Diffuse injuries, we fortunately have been able to still admit, but we had thought about protocols in how they could be managed on ventilators in district hospitals without intracranial pressure monitoring, using the same sort of protocols that Randy Chestnut has devised during his ICU protocol study. Fortunately, as I said, that really hasn't been an issue, and we have been able to maintain admission across most of the UK. So if you look at cranial injury, this was the algorithm during COVID. Are normal sources available? Yes, would be normal practice. No, if the patient required acute surgery, there's no doubt we would transfer them and undertake surgery. If they have diffuse injury and require ITU, you could consider local admission, remote management, regular CT, other ways of managing these patients. And milder TBI and chronic subdural, again, a local admission, chronic subdural coming across if required but a tendency to keep mild and moderate TBI out of neurosurgical centres. We have similar guidance for neuro-oncology, neurovascular conditions that I won't go into in the interest of time. On the background of this, there's been a recognition that there's an awful lot of research going on in COVID, and really in the concerns of the numbers and the impact on surgical practice, the Royal College of Surgeons convened this COVID-19 research group. We know that the pandemic poses unprecedented challenges and raised many questions. So there are a number of investigators. This doesn't only apply to neurosurgery, it's across all surgical specialties, to get some research projects up and running quickly. So the group convened to really share ideas, collaborate, support recruitment, and identifying funding opportunities to provide data to assist in decision-making and policy. One of the amazing research opportunities that's come out of this work is a recognition by the government ethics committees that this is moving rapidly, and it has been incredible how quickly we've been able to get ethical and other approvals for these studies, sometimes in days, which historically would have taken months, and hopefully that's a legacy that will live on beyond COVID. The group meets regularly. Initially, it met weekly, currently meeting monthly, discussing the COVID research projects with an aim to collaborate, recruit, and fund, and also trying to look at new publication strategies. You know, we are not in a position where we can wait for prolonged peer review, hard copy journal outputs. We need to be smart. We need to look at repositories, live updates, getting this information out very quickly. And we're doing that in conjunction with the library at the college and the clinical effectiveness unit. So this is the current surgical portfolio from the college. It extends to over 50 research projects with a range of different methodologies, cohort studies, systematic reviews, some qualitative research, translational studies, and laboratory science, both general, specialty specific, national, international, adult, and pediatric. There is a whole different range of research projects. They range from the COVID surge. This was an enormous study of many thousands of patients worldwide. What did it teach us? It taught us that operating under general anesthesia in patients with COVID or at risk of COVID in the perioperative period has very high stakes. The mortality in patients COVID positive undergoing any form of surgical procedure was 25%. And in those with respiratory complications, that rose to 38%. So the consequence of that is some of the members of the group have thought, if surgery is so high risk, maybe we need to change the bar for decision-making for surgery. And that's led to a number of interesting developments. For example, a move away from surgery in appendicitis. So an example, a classical surgical indication, COVID positive patient now being treated with antibiotics. And that's these studies in both children and adults. So they have shown that you can manage appendicitis safely in certain patients without surgery. Also, looking at other forms of anesthesia, a lot of hand surgery previously done under general anesthetic, perhaps looking at regional or local anesthesia. There's been some other quite nice studies, what we call the PPE challenge, where investigators were invited to submit novel ideas of PPE, less restrictive in terms of operating. Qualitative research, this is the Lotus C19, looking at the experience and mental health of healthcare professionals operating within a COVID environment. The NIHR incubator, a number of projects, particularly looking at aerosol transmission risk. The science of how aerosols are transmitted, there is quite a geeky organization called the British Aerosol Society. This is their moment. They have suddenly come to the forefront in terms of how these virus particles and aerosols move. And this is a number of different aspects to it. Interestingly, even looking at the rate of airflow change and the way airflow moves around the operating room. Here's some of the examples. So data on operations cancelled and postponed to assist the recovery phase. We know the waiting list is growing. We've now captured that data. That will help us triage surgery. As I've discussed, we've learned about the risks of operating in the context of COVID. Can we avoid surgery, appendicitis, hand surgery, and other conditions? This is acute mesenteric thrombosis with medical management. One of my colleagues, Alex Genadis, is a member of the COVID RCS research group, and Alexis has performed this study similar to Ellen's study, looking at the impact of COVID on referral practice for neurosurgery across a number of neurosurgical centres: Cambridge, the Walton Adult Centre in Liverpool, and the Paediatric Alder Hayes Centre in Liverpool, to look at the change in referral volume and epidemiology, the change in management, and the effect of the burden on morbidity and mortality. So looked before and after. I'll just share with you a couple of the results. What was interesting, and again, Ellen discussed this, was a change in the nature of the pathology that we were seeing. We did see a reduction in the number of head injuries, down by about 20%. That was actually quite short-lived, and then it has come back again. During the pandemic, we saw less road traffic accidents, but there were a number of people perhaps consuming a little bit too much alcohol at home and falling down the stairs. And then as the lockdown began to release, we were seeing quite nasty motorcycle road traffic collisions as people were trying to get out and about. We also looked at how the pandemic had changed decision-making, and what was quite reassuring was that only very small numbers of patients were managed differently as a result of the COVID-19 pandemic. So this concern that we wouldn't be able to admit patients with diffuse injury for ICP monitoring and management didn't come to fruition, and we were able to accommodate those. So during the pandemic in neurosurgery, we did see a reduction in referral volume and the proportion transferred. There were some regional differences, and this is ongoing work, and I think it will be interesting to see the impact of the second wave, which sadly is now beginning to hit us. So thank you, or thank you to Nicholas, to Ellen, to Tony, my colleagues on this webinar, to the research group collaborators, and all colleagues in the EANS, and particularly the EANS office team, and all the support that particularly Anna's given for this webinar. And I'm now going to hand over to Professor Figaji. Tony.
Thanks, Peter. Let me just get my screen up. So I'm going to take a slightly different perspective, and decided to speak a little bit more on the societal aspects and the ethical aspects of the COVID-19 epidemic, all the decisions that were made and how they impacted on our practice now and for the future. But also with a slightly different perspective from South Africa. So it's outside of Europe, in a very different set of circumstances, a very different healthcare setup and balance between healthcare needs and resources, but with an interventional approach that is quite similar to yours. And I'll look at a little bit about how that played out. So I'm from Cape Town, as many of you will know. Cape Town is at the tip of the continent. It's a beautiful place, and there are some upsides to it. One of those in the COVID-19 epidemic is that there's lots of space around, so you can get out and about, which for one's mental, psychological health in a time of lockdown really makes a big difference. It's also a big tourist hub though, so it was always going to be the first place that registered the first COVID case, and that indeed was the problem. So we peaked a lot earlier than any of the other regions, and that also had all sorts of political ramifications, because the Western Cape region in which Cape Town sits is governed by the opposition political parties. So it played out in all sorts of interesting ways. So just to put it in context, to compare both our population and space to the United Kingdom. So we have similar populations. The UK is a bit larger than us. It's about 66, 67 million people, but on a much smaller landmass and a very different population demographics. So our average age is a lot younger, but in terms of our healthcare problems, of course, a much higher burden of diseases of poverty, of socioeconomic diseases such as TB and HIV. And there was a huge amount of anxiety about how that would play out in the COVID-19 epidemic. So our South African government response has been one of the more noteworthy responses globally. There are a few things that they got right, and they got right quite early, and there are a few things that had been questionable. One of the things they got right was that there was a very quick and coordinated response. It was very firm, it was very definitive, there was good public buy-in. Everybody wore masks very early on, got into sanitizing, social distancing, etc. But within some constraints, of course, particularly in our township areas. So South Africa is an upper middle income country, but the gap between the poorest and the richest or the wealthiest in the society is quite large. So you have some very wealthy areas, but some then very, very poor areas, the townships where people live very close and don't have running water and don't have electricity, and all the implications that has for social distancing and good hygiene. For an upper middle income country, you had a reasonable approach to testing and reporting. We had a very high rates of testing in the beginning, and then that fell off slowly, as it did in many other countries, and had to titrate based on how reasonable it was and how effective it was. Very good data collection through our Medical Research Council. We got weekly death rates reported and daily hospital updates. On the downside, perhaps, ours was one of the harshest imposed lockdowns globally, particularly in the first couple of months. We had a very, very strict lockdown, which I'll talk about in a moment. It was very, very heavily enforced. They took no prisoners. Well, ironically, in fact, they did take prisoners, because if you are found walking on the beach, and we've got many beaches, you were liable to be arrested. And of course, there were many of the unintended consequences of a strict lockdown that I think over time we'll look back, and there will be different opinions, and we'll probably never get to an agreed version of what was good and what was bad about it. So this is what our timeline looked at. Our first case was in early March. First local transmission a few weeks later, and then about the third week of March, a national state of disaster was announced, and an initial 21-day lockdown was announced when we had 400 cases. That in early April was extended, so that we called level 5, and level 5 for us meant that no alcohol could be sold, no tobacco could be sold, no restaurants were open, no public gatherings. There was a strict curfew between 8 and 5 p.m., at least 5 a.m. Only essential workers were allowed to be on the road. No travel was allowed without permit, so you could be stopped on the road and you'd have to demonstrate your permit. You weren't allowed any outdoor exercise. So by the time level 4 came around, you could go outside to exercise, but within the constraints of 5 o'clock in the morning to 9 o'clock in the morning. So in that window, just everybody was out on the streets to get a bit of fresh air and exercise and just get out of the house. And then slowly we've de-escalated those lockdown procedures until now we're down to level 1, which our economy is slowly trying to recover from these kind of 7-8 months of kind of really, really hard grind. So in our current status, as I said, we're a population of about 60 million. We have 673,000 cases and 16,000 deaths. At the moment, I'll show you the graphs briefly. We have declining cases, we have declining hospitalizations, we have declining deaths. We're going into spring, so hopefully that may buffer any second wave that we may be experiencing, particularly now that restrictions are being gradually relaxed. So in the top left over here, that's in our major adult hospital here in Cape Town. Adult hospital admissions peaked in July and have been declining ever since. This is what our cases look like at the bottom left, and it's not just reflecting decreased testing because it's mirrored by the number of deaths, it's mirrored by the hospital admissions, ICU admissions. So we've seen a sharp decline since our peak in July, and whether we will have a second wave or not, it's difficult to determine. A big difference between our population and your population, apart from the age demographics and the socioeconomic aspects, of course, is that we've just been through winter and we're going into spring now, and that may have an impact as well. So the effect on the economy, really, that has been devastating. 3 million jobs have been lost. Our unemployment rate was already high before COVID-19 struck. Corruption has been common in the procurement of PPE, inflating the costs of PPE. Our country is estimated to lose 280 billion rand in tax revenues for the financial year, and it's obviously a huge amount in terms of the tax revenue loss. But what it doesn't really tell you is the human cost, because middle class jobs and small businesses have gone under, and that has a huge knock-on effect on the people that they are employing. Our GDP decreased by 16% from the first to the second quarters in the beginning of the year, and we've seen increased poverty and increased food security that we hadn't really been seeing at to those levels for many years. Our local currency took a beating, and you can see whether you look at it against the US dollar, the British pound, or the euro. From the late February and March, it lost about 20% of its value. And unfortunately, it's not just for our currency, it's largely emerging market currency. So you see that in Brazil as well, in any emerging market currency. And that's just one of the tragic things that's just very difficult to deal with in global crises. So when there are global crises, investors rush to safe havens, and the economies in the world that generally need the greatest help are the ones that suffer the most, because the currency takes a huge beating. And it's almost irrespective of what the crisis is, any crisis that emerges, a financial crisis, a health crisis, you see the exact same pattern. What about its impact on our surgery and surgical research programs? Well, our surgical operations at our adult hospital is a little bit different in our pediatric hospital. Our surgical operations reduced by 2/3 compared with previous years. Our surgeons, neurosurgeons included, have been redeployed to medical services. So we had neurosurgical consultants working in casualty and COVID-19 wards as medical officers and interns. The unexpected benefit of a strict lockdown, because we couldn't buy alcohol for probably about 4 or 5 months, was a reduced trauma burden. There were few people out on the road, and fewer motor vehicle accidents. All emergency patients, I'm sure in your unit as well, are treated as persons under investigation. And that obviously has a logistic difficulty with getting through enough cases during the course of the day, and COVID-19 cases done in a special operating theater, the whole different set of PPE regulations, and that has, again, a knock-on effect on how many cases you can get through during the course of a day. Our surgical research is essentially terminated, including our clinical programs, and including those that have potential benefit for patients, but that we're running as research programs. So our microdialysis program had to come to a halt because it's completely funded through research. We need research staff to run it. And then the impact of our currency depreciation. So everything costs 20% more. So all our clinical consumables for normal clinical work, all the consumables for research, at least 20% more expensive because of the currency depreciation. But in real terms, it's much worse than that. So for instance, I put in an order for microdialysis consumables for our neurotrauma program in January, but it was only processed in kind of late February. By that time, the quote compared to the real cost was completely different, of course, and the real cost. It had to take into consideration the currency depreciation, as well as now a higher cost for transporting or shipping was 30% more expensive. And then delays in elective imaging. But on the upside, one of the things that stood in stark contrast to the experience, I think, that some of our colleagues and friends had in the UK and in Western Europe and in North America, was that we are familiar with resource constraints. So I think for many places in high income settings, it was a psychological struggle because staff weren't familiar with the pressing need to balance limited resources with a need that was at some points at its peak completely overwhelming. And then we have to look at the greater impact of COVID-19 on all the healthcare conditions. Now, in South Africa and in Africa at large, there's a huge amount of focus on infectious diseases that has all sorts of ramifications. But that focus on infectious diseases, including the funding that comes from it, is well beyond the actual burden of disease. And we are guilty of not paying attention to patients with non-communicable diseases, including cancer and neurotrauma, a lot of the things that present to us as neurosurgeons. So one of the clear things, the very worrying aspects, and we see this in all countries, is the rapid rise, particularly at its peak, of excess deaths. So those are the deaths that are unaccounted for, that are much higher than the baseline, but they're not known to be COVID-19 positive. Now, it may well be that some of those deaths are indeed COVID-19 deaths that just weren't tested, but the anxiety, of course, is that these are patients who are not presenting for surgery, who are not presenting to their local hospital because of all the knock-on effects of COVID-19, the impact on the hospitals, and the impact of lockdown. For surgery specifically, it's estimated that we will have a backlog of approximately 150,000 procedures, and if we increase our surgical capacity by 10%, it's going to take us 2 years to eradicate that. So when one thinks about ethics, this really is about the balance of benefits and risks. In our country, there's a huge amount of anxiety about what it would do to patients with TB and HIV, and that affected, the direct effect has been relatively modest. It seems that they have a higher risk of death, but it's very difficult to exclude the possibility of residual confounding because of the socioeconomic factors. But it is very likely that the indirect effects on patients with TB and HIV, because it's socioeconomic and because it's about access to healthcare, are going to be much greater. Just to put it in perspective, in 2018, the number of TB deaths in our country is 63,000. Injury deaths also around about that number per year. And since COVID-19 started, we've had 16,000 deaths, COVID-19 deaths since March. So when you look at it in terms of the burden of TB and the burden of injury, one really has to question about where our priorities should be best set. And as you saw earlier on that I spoke about, there's a substantial increase in excess deaths, which leads us to question whether we got it right. The COVID-19 prediction models that we base much of our thinking about, and it's always easy, of course, to criticize in retrospect, but they're thought to be overly pessimistic. So they predicted 8 million infections in mid-August. We haven't had 1 million infections yet. 40,000 deaths by November. We've had 16,000 deaths. So ethically, how should health resource allocation be applied during the COVID-19 pandemic globally, but particularly in South Africa, where our healthcare needs and the mismatch between resource and need are so different to what you would experience in Western Europe and in the UK. And this was a paper by a colleague of mine in neurosurgery, where they questioned this balance. And this was relatively early on in the epidemic. And if I can quote from it, as for other diseases, principles of healthcare rationing must apply, with COVID patients competing for the same limited resources as non-COVID patients. For example, with the average ventilation and ICU time of COVID patients exceeding that of many non-COVID patients with potentially better outcomes, the latter should not be denied care at the expense of the former. The difficulty for us was that certainly at the peak, our ICUs were filled with COVID patients. The outcomes for a patient who had to be ventilated at its peak was particularly dire, much higher than the 40% that Peter just quoted. And so we had to and have to still ask ourselves hard questions about how to allocate resources based on the likelihood of patients having a good outcome. And we don't have a good answer to that yet. So very lastly, I want to ask, who are the people who advocate for infectious diseases? There are several. In Africa, it will be our national governments, it will be Bill and Melinda Gates, it will be Wellcome Trust and the NIH, and the vast majority of that funding goes to infectious diseases programs, infectious diseases research. But who advocates for surgery? Who advocates for surgical conditions? And even more pointedly for us, who advocates for brain conditions, for neurological conditions, for neurosurgical conditions? Those patients are as deserving as any COVID-19 patient or patient of TB or HIV, but they don't have the same advocacy voice as the other conditions. And that, of course, is a challenge for us because we are the ones who should be advocates for them. So on that note, I'll end, and happy to take any questions. Peter and Alan are going to run the question and answer session, and we'll have a look at your questions and then see how many we can squeeze into the time remaining. Alan?
Yes, hello. Thank you for a very nice presentation.
So please post your questions on the Q&A rather than in the chat. The first question to Alan from Nicholas. Could you briefly describe the post-mortem findings with regards to inflammation in the brain?
Yes, I can show you the slide that you would think I would be an expert on Zoom by now, but I had problems sharing my screen. And I think Nicholas maybe refers to this one when we do the postmortem analysis and also biopsies in this patient, which is surprisingly that we see very little inflammation in the sections that we have analyzed by now. And so we focus on the ACE2 receptor, which has been mapped with the HPA program, the Human Protein Atlas program, and we don't see the results that is published from the animal studies. And we also try to see if we can detect the virus in the brain tissues that we have. And we have a scope for it's a part of the inflammatory system that I cannot reveal now, but the usual markings for the inflammatory markers are not detected in these slices that we have. And this one is actually from a patient, it's a white matter tissue from a patient who suffered severe demyelination inflammatory response, but that could be seen in the MRI pictures. But we could not detect any signs of inflammation, but one has to consider that it's just a small part of the brain. A larger study needs to be, of course, done, but it's not possible for the patients to survive. But for the autopsy, we have done several sections, different areas of the brain, and we still don't see a huge inflammatory response. But there is one specific part of the inflammatory response that we have looked at that we have very interesting results, but I could not show those picture. But it's not huge as you would expect in encephalitis cases that you would see in the cases that we have studied. So.
Great, thanks, Helen. There was a question for me about whether we are experiencing a second, or whether we will be experiencing a second wave, and how prepared are we for it. We haven't experienced a second wave. I think the gap between the peak in the UK and the second wave was about 3 or 4 months, and our peak was in July. So we will see. It may be mitigated by the fact that, as I said, the weather is improving, whereas viral diseases tend to be, their peaks tend to be in winter. Are we prepared for it? I think we over prepared for it. I think you know, the goals of preparing for a peak like this, there are two aspects. One is to limit morbidity and mortality, of course, but that always has to be balanced against all our goals. The more pressing goal here, which we took our cue from the experience in Italy, was to have a very hard approach to protect our resources so that our hospitals don't get overwhelmed. And so we did that. Our hospitals weren't overwhelmed. And like Peter was saying, there were these Mercy hospitals that were opened. And for those of you who attended the INTS meeting, the International Neurotrauma Society meeting, we hosted here in Cape Town a few years ago, you'll remember the Congress Center that we hosted the meeting in, that the whole of that conference center was converted into a hospital. And that was decommissioned probably about a month and a half ago. So are we prepared? I think we are over prepared. The difficulty is our economy prepared to bounce back from the beating that it took. Then the next question was a long question. Apologize for it, Alfonso. Do you have any clue on the number of patients not being correctly treated due to emergency services disruption in the first wave? He's writing from Spain. There were no mobile ICUs for non-COVID patients. How about in England, where you have a good account of all trauma cases and had a first wave? What would your strategy be? There are no registries of accidents in Spain. So I think the gist of his question is, we all have anxieties about these excess deaths, the knock-on effects on neurotrauma patients or oncology patients. How many of us have decent data on those patients who are dying, where their deaths aren't being recorded? And I'd imagine that for us as a community and as an advocacy group, that kind of data would be really, really important, particularly when the talk comes around again to allocating resources away from surgical management of patients to the management of another wave of some other virus.
So Tony,
Peter, how's the UK data look on that?
Yeah, so we do have data on this. So the number of patients on the waiting list has gone up by in excess of 500,000 very quickly, and that equates to about an 11-month hit across surgery. So that, you know, the pandemic was bad for maybe 2 months. That's actually cost us 11 months overall. So that's what we're having to face. I think the second part, Alfonso, of your question is about the trauma cases. And the one thing that I think we got right is that we were very concerned about the impact on patients with neurosurgical pathology who did not have COVID, and that really related to traumatic brain injury and subarachnoid hemorrhage and access to intensive care. So we discussed with the hospital that we would ring fence 10 beds on the ICU for those patients from other hospitals. So however bad COVID got, we would always keep those beds for the other patients. And I'm very grateful to colleagues in intensive care and the management of the hospital for enabling us to do that. And we will continue to do that. So if you can protect ICU beds for these other patients, then, you know, I think that's a very valuable resource.
So maybe I can jump in with one last question. We just gone the hour now. So Peter and Alan, if I may ask a direct question to you, if you were Peter, if you were Boris Johnson, you were Prime Minister. Alan, who's your Prime Minister?
That was the pause, Stefan Löfven.
Okay. If you were Prime Minister of the country, but with all the sensibilities and the knowledge that come from having been a surgeon, how do you think, with the knowledge that you have today, how would you have managed your country's pandemic without criticizing anyone? So Boris won't be on the phone to you tomorrow, Peter. Your job is not at risk. But with the retrospectoscope, what would you have done, if anything, differently?
Well, I'm very grateful that I'm not Boris Johnson for several reasons. What would have done differently? So I think if you're looking back, and in terms of the decisions that were made, we should have locked down earlier and probably not so severe in terms of the economic consequences. I think it was a bit like you said, Tony, possibly too much. And for me, the biggest priority and what we've lost is education of school children and the universities. And that's where I think we slightly lost focus. And what's interestingly now is, as we're coming up to the second wave, and I think the government have got this right, they are adamant that they will do everything they can to keep schools open and children at universities. So my feeling is to try and, get everybody back as much as you can, and those who are vulnerable, the elderly, those who need shielding, continue. If they need to shield, they need to shield. But I think the rest of us are going to have to try and crack on with life, because I don't think the economy could take another hit like it did during the first wave.
I can just, I think that was very important for Sweden, because we never shut down the schools, at least up to the 9th grade, and which was very important, because if they had been shut down, I mean, all the people in the healthcare would needed to stay at home with their kids. So that would be a tremendous hit to the healthcare. And to your question, I'm not very, very critical, but I think what I think maybe we should learn in Sweden from this is to have a plan for a pandemic or a similar situation, that really you just, push this red button and things are processed, that we don't have to wait 3-4 months for things to happen. And the other thing that we saw that, for example, Finland had, that we didn't have, that they just opened their stores for, protective personal equipment. So they were never, at least what they were reported, that there were never any shortages in Finland, because somehow they were prepared for this, while Sweden was less prepared regarding that matter. So I think, although we managed it quite well, I know there are a lot of critics who would not agree with me, but I think, of course, we have a lot of things to learn, that systems and prioritization could be put in place much earlier than we managed to do this time. And I think we will still see the coming months, the impact it had, for example, for the neurosurgical cases and departments, the prioritization we did, and the shift in our organization, the changes we had to do, the adjustments we had to do, in particular in the epicenter in the Stockholm area, where they did need to do, they got the biggest hit. So I think we still need time to evaluate the impact and try to, see where the mistakes were. Because we know this is not the last pandemic, so we really need to study and try to learn for the next one.
So yeah, as I said, our currency is depreciated. It's kind of 20-25% down. So Cape Town's a good place to come on holiday if you can just get here.
And then Nicholas made a comment about dying from COVID and dying with COVID, and I think that's really important too. If you look at the numbers, it is really important to emphasize, many of these patients had serious other pathologies and they died with COVID rather than of it. And I think we all need to be conscious of that when we look at the data.
So there was a question about why do I think the projections for the effect of COVID-19 were overestimated? Probably not the best person to answer that, but I'll give it a go. I'm not an epidemiologist, I'm not an economist, but generally I've very, very rarely come across a model in anything that is actually accurate. So I'm not a great fan of modeling. And I think the truth is that modelings do their best to take into consideration all the various factors that may influence an outcome, but only the ones that they can identify. So the problem is for an epidemiologist, they can't identify some of the things that they don't think about. So that might include the impact on surgical services and waiting lists and morbidity and mortality for patients who can't wait that long for their delayed surgical operation. So they may not take that into account. And they also can't take into account how people's behavior are affected by their prediction. So they make a prediction, the government intervenes on the basis of that prediction, the public respond to the government's intervention. And whenever there are human factors, they make a mockery of our ability to take all of those considerations and make a mathematical algorithm or equation out of it and come to a sensible answer. So that's the difficulty. The difficulty is just human beings. Now, I think a lot of epidemiologists take that into consideration, and they've got optimistic models and pessimistic models. And whether they use the optimistic or pessimistic model depends on what they're most worried about. And for us, they were most worried about a healthcare system that was going to be overrun and a potential explosion in TB and HIV. So whether it was because of their models that the healthcare system wasn't overrun or because we were never going to get to that, very, very difficult to say, but the models were very, very out. Now, one can say that's okay because if it's a pessimistic model and we do better than the pessimistic model suggested, then that's okay. At least we averted a disaster and at least we didn't underestimate it. The problem with that is that if your lockdown measures, your interventions have a devastating effect on, or devastating knock-on effects on surgery, for instance, or on the economy, then one has to step back and say, overall, on the whole, were the benefits of these interventions greater, or were the downsides, the risk greater? And that, I think for many of us, it's going to be 2-3 years down the line before we can have a reasonable interpretation of that.
I agree. And I think that's why it's so important also, as was presented previously, all these different studies in order to try to understand, I mean, of course, the impact of it on neuro, but also on our, you know, daily work and what it did to our, you know, what the effect on the outcome actually was. And I think, as you say, it will take us maybe a few years to understand it.
So one of the comments in the chat was about me, bitter, but very instructive. Kind of explains my personality. I think it is bitter, and I think the overall effect on all of our lives has been dramatic, to say the least. It also has had a dramatic negative effect on the patients that we treat or we try to treat. But I think as neurosurgeons, we're an optimistic bunch. We believe that we can make a difference. So we get up in the morning and we work late at night because we believe that even in the most adverse circumstances, we can make a real difference to the lives of people. And we can do it in a way that makes us feel challenged, ethically challenged, cognitively challenged, physically challenged. And that's why we do what we do. So even if there are bitter things that we have to face, I think we don't lose hope, we don't lose optimism, and we don't lose enthusiasm for it.
Well said, Tony. So the time is 18:14.
Yeah, I think that's fine. Eh?
And I think maybe Tony's optimistic and enthusiastic words can wrap up the webinar. What do you think?
Well, one of the benefits, I suppose, of this terrible situation is that we can have webinars like this. So just like to thank my colleagues as panelists and the fantastic Q&A and the participation from everybody remotely. So if there is one bonus, it's that we can still meet and talk to each other.
Yes, and thank you all for participating.
It was great seeing you guys again, but it does remind me that as much as I appreciate these webinars and ability to connect with each other. I look forward to seeing you in the flesh and having a drink again together.
Hopefully 2021.
Boris Johnson says there's a rule of 6. It's not about 6 people meeting, it's about 6 pints, Tony, all right?
Look forward to it. Alan, Peter, thanks so much.
Thank you, everyone. Thank you.
Bye then.